Welcome back to another episode. During Epilepsy Awareness Month, I thought it was equally as important to talk about seizure mimics. As a chief of epilepsy at a level 4 comprehensive epilepsy center, we have an epilepsy monitoring unit. And in our epilepsy monitoring unit, like other epilepsy monitoring units, we often see patients who have seizure mimics. You might be one of those patients. Perhaps you've just received a diagnosis of psychogenic non-epileptic events or functional neurological disorders with seizures. Basically, what all of that means is that you are having some event in which you move your body, some symptoms are happening, yet the person reading your EEG has not seen any evidence of a seizure activity on the EEG. You might be feeling hopeless because you may have been struggling with this for a very long time, wondering how to get better. There is hope for you as well, but making the correct diagnosis is so important. The correct diagnosis is so important. So you no longer have to waste time with treatments that may not be what you need. So this is the first step in towards getting tailored treatment. Now, this video does not serve as medical advice for anyone other than the patients that we treat in our center. This video does not replace your interactions with your healthcare provider in any shape, form, or fashion. You should still speak with your healthcare provider. This video may just be used for inspiration. Maybe it helps you to talk with your doctors better. Maybe it gives you some questions that you might want to ask. At any rate, during this video, we speak with an expert, Dr. Matthew Kreidel, about psychogenic non-epileptic events, also known as functional neurological disorder with seizures. And he leaves so many gems. I think there are gems on the table for physicians, neurologists, aspiring neurologists, patients who may have been diagnosed with this disorder, and also for the family members that support those patients. At any rate, although we'll never know how many people this helps, we hope that it helps so many. Even if it's just to inspire you to talk with your healthcare providers. Let's get into it. Just making sure I got my paper all squared up here. Well, so welcome. Good morning, guys. Thanks for
Good morning.
coming on to this episode. Have two guests this morning. First one you've seen before, Veronica. I'll let you go ahead and introduce yourself.
All right. I am Veronica Lack, and I have been a nurse for 30 years, but I have been in the epilepsy monitoring unit for the last, I think, 7 or 8. I've learned a lot working in that unit. It's been a great experience.
Good deal. And you have a passion for our topic this morning, which is
Oh, I do. Yes.
functional
Yes.
neurological disorders, specifically psychogenic non-epileptic events. And
Yes. And this was something I didn't even know existed until I started working in the epilepsy monitoring unit.
yep,
So it's turned into a huge passion of mine. Yes.
good deal. And that brings us to our expert this morning, which is Dr. Kreidel. I'll let you go ahead and introduce yourself.
Sure. I'm Dr. Matt Kreidel. I'm a clinical psychologist licensed in the state of Georgia, and I am the primary provider of psychological services, specifically therapy, in the Department of Neurology, to supplement the extant psychological services of assessment provided by Dr. Kelly Stanek.
Very good. Very good. And I'm Dr. Moorhill, the chief of our epilepsy division. So this podcast has become very special to us as we collectively work together to, share information with patients and patients' families and probably aspiring neurologists as well about epilepsy. November is Epilepsy Awareness Month. And so one of the things that we do is we run an epilepsy monitoring unit. And I always say to patients, at least when they're diagnosed with PNES, psychogenic non-epileptic events is that, within our epilepsy monitoring unit at any particular time, about 40% of the patients who get admitted there often end up with a non-seizure diagnosis, such as psychogenic non-epileptic events. And so I thought it was very important to have the expert here to talk about that kind of workflow and maybe some things that those types of patients might want to think about during Epilepsy Awareness Month as well. So, psychogenic non-epileptic events is definitely a EEG proven diagnosis, right? So typically the diagnosis of that is made when patients think they are having seizures. There are a lot of things that might look like seizures. However, this subset of patients comes to our epilepsy monitoring unit and there is no EEG correlation with their event. Right. And then also the semiology, or what the event looks like, does not also look like it could be a seizure. Right. So that's how psychogenic non-epileptic events are diagnosed within our facility. Right. And then we refer those patients off to Dr. Kreidel for treatment. And there's lots of different treatment. But I guess one of the biggest things is, from a clinical psychology standpoint, how do you go about explaining PNES to patients and to their families?
It's a good question. I think a lot of individuals have different reactions when they get that diagnosis of, as you described it, PNES. I typically use the term FND with seizures. There's many, many different terms out there. And that's part of the process too, is figuring out what language the patient's most comfortable with and then following with that. Patients have different reactions when they get that diagnosis. Sometimes it is a reaction of relief. It's like, oh my gosh, like we have an answer. We know what this is. We can maybe do something about it. I'm not in this limbo anymore, because we also know that the average time from onset of these events to diagnosis is 7 years. So people may have been suffering with these very scary, very unknown things going on for 7 years. Getting that diagnosis can be a relief. Other patients, sometimes not so much. There's unfortunately a lot of stigma around these events, and people may perceive this diagnosis as, well, it's all in your head, or you're making it up, or it's psychiatric, right? And that's distinctly not true. So one of the first things I lead with when I'm describing these is, I couch it in the rest of medicine. I say, what you may not know is that there are functional disorders present throughout medicine. Fibromyalgia is a functional disorder of several different systems. The one patients probably most often know is irritable bowel syndrome, IBS, is a functional disorder of the gastrointestinal system. Same thing with what we would call functional dyspepsia, where you're having a lot of reflux, and there's just not really a physiological explanation why. We can scope, we can't see anything. And I say the same thing is here. We have looked at your brain the best way we know how, through EEG and actually watching your movements. And together, those things really give us a pretty clear picture that these are not epileptic. And we can do something about that. And so one little kind of phrase I use as well for patients is like, you may have heard people say like, oh, it's all in your head, or you have this idea it's all in your head. Well, your brain is in your head. So technically everything is in your head. And that usually gets a good chuckle and kind of lightens the mood. And, you really have to meet patients where they're at. Some patients are really on board with this diagnosis and feel relieved, some not so much. And so once you can kind of figure out where that is, then you can decide how to proceed. Do we jump right into, this is how you treat it, this is what you need to know? Or do we need to kind of slow down a bit and go, what else are you thinking this might be? Let's get inside your head and say like, okay, what do you think it is? Oh yeah, that would be really frightening if it was some kind of brain tumor. Yeah, so let's explain why it is, or it can't possibly be, right? To really kind of assuage some of those concerns. So for me at the top, it's, how are you feeling about this diagnosis? And then that leads us into tackling those questions that still remain.
And I think before we get into the meat of this, I just want to, because there's going to be patients' families who might listen to this too, and they might say, he said functional. What does that mean to the layperson? What are they supposed to take away from the word functional neurological disorder with seizures?
Yeah, it's a great question. So functional neurological disorder has a very long history. And some of that history is rather unfortunate. Way back then, we called it hysteria, and it was this idea that only women experienced it, and we thought literally that their uteruses were floating to their head, and so that was causing Of course, that doesn't happen, right? We know that's not true. As time has evolved, we started to use terms like psychogenic, psychosomatic. The modern term in use is functional, but a lot of terms still hang on. That's just how terminology works. Functional disorders are sort of defined in the name. There is a problem with functioning. And so a lot of patients are, again, they get back to this like, well, am I making it up? And it's like, no, you're clearly not making it up. You are having a seizure. You are having an event. It's just not an epileptic one. Am I making up this indigestion I'm having with IBS? No, it's a functional problem of the gastrointestinal system. And so when patients ask that question, what do you mean functional? I'm like, we often use this comparison of a software hardware problem. We say, we've looked at the hardware, we looked at your organs, brain, gut, whatever else. We're not really seeing the things wrong that we might normally see, but something is absolutely happening. That software isn't working where things are not talking to one another. And so that's not so easily observable, at least yet. But we know it's happening because we can see it.
Mm-hmm. Mm-hmm. So with a person who gets diagnosed with 7 years is a long time to have an event. Meanwhile, just to unpack what that patient might be going through, because I think one of the big things that's important to me throughout this series also was to kind of demystify some of those, the conditions that patients are just really not, that they don't understand. And maybe some healthcare providers don't understand these things either, especially functional neurological disorder. As a neurologist, this is not what I treat. Right. So, I wouldn't say that I'm an expert with functional neurological disorder or psychogenic non-epileptic events. Right. And so, 7 years of having events and going to I would assume going to doctors, probably wound up at a neurologist office, maybe a seizure specialist office, and to after that long journey you're thinking, these patients are probably thinking, wow, I have drug resistant epilepsy. I've been on this medicine and that medicine, and that's not working and nothing's working. I keep having these events. And then they probably build up, wow, these doctors don't know what they're doing because they're just giving.
Probably lots of ER visits too.
Yeah, they're just giving me lots of medicines and I'm not getting better here. What's going on?
Right.
So that's a long journey. I did not know that 7 years. I certainly have seen patients who have gone longer, thinking that they have a seizure disorder and they don't actually have a seizure disorder.
Right.
So when it comes down to the conversation, the poor unsuspecting doctor walks into the epilepsy monitoring unit, having just met the patient 4 days prior, and says, well, we recorded these seizures, or we recorded these events, and they're not seizures. Right. And so I think a lot of my colleagues probably walk away from this conversation because those reactions that you mentioned, they're real. Like, I feel like there's 3 reactions. There's 1, relief. Thank goodness this is not epilepsy. There's 1, nope, doctors are still stupid. You guys don't know. That's not it. I'm sorry, that's not it. He or she is still having seizures, right? And you just don't know what you're looking for. Or maybe you missed something. Or the third one is, kind of avoidance of the situation too. Like there's different levels of, I feel like, stages of avoidance of, well, especially, sometimes I think with functional neurological disorders, it's hard to describe how somebody might be moving their body, but it not be something that they know how to control, right? Like it sounds, yeah. So
Doesn't make a lot of sense.
it doesn't make a lot of sense,
Mhm.
right? And I'm just
And it
imagining
helps.
that patient's family on the couch listening to this conversation. They're probably like, oh my gosh, what do I do with this?
Right.
Yeah, patients can absolutely accumulate years and years of stigma, whether that's from medical providers or family members or friends. FND Hope is a great international organization that undertook a massive study, a couple hundred, I think 800 people, and looked at the presence of stigma in people living with functional neurological disorders broadly, not just of a seizure type, and found stigma to be incredibly high. No surprise there. Even to the point, I would hazard, that some patients experience medical trauma, that these experiences have made them afraid and avoidant to even go see a doctor. And like you said, this question can come up of like, well, I don't understand. If I'm not making it up, and it's like, how am I doing this? And it can be helpful for some patients to talk about what we suspect to be one of the major mechanisms, which is dissociation. Sometimes these seizures are known as dissociative seizures. I don't think dissociation captures the whole pie, but it does often capture a chunk of it. And the way I explain dissociation to people is, have you ever had the experience of driving somewhere really familiar, say your route to work or to grandma's house or wherever, and you sort of kind of check out, and next thing you know, you've gotten there, and you're like, oh, wow, my gosh, I didn't realize I had traveled that far. That's dissociation. It's simply a disconnect between what is happening out here and what is happening in here. Daydream is a very mild form of dissociation. On the extreme end, some people experience what we call dissociative disorders, where they don't feel real, or they feel the world around them isn't real, what we call depersonalization and derealization. Dissociation, as it falls into the functional neurologic realm, is somewhere in the middle. There is a disconnect between up here and down here and out here. And so because that misfiring, that miswiring is going on, the brain is sending out signals to the body, and the body is sending signals back to communicate, okay, we need to do this type of movement. And I also like to connect for patients that it often has to do with these systems in the brain. It's hard to point to where they are because they're deep in our what we call hindbrain, or our primal brain. And the amygdala and insula are highly implicated in functional neurological disorders, especially with seizures. The insula controls both brain-body connection and has an influence on emotions. The amygdala has an influence on emotions as well. And so you might imagine that when those systems are implicated, anything that gets sort of that fight or flight, sympathetic alarm system wired up, the way the brain somehow has learned to handle that is to have this epileptic looking event that is ultimately non-epileptic, right? And so, part of it, sometimes I say to patients, it's not the most satisfactory answer, but I'm like, brains are weird. Brains are weird. And there's one big advocate in this field of work, who I might talk about a little later, who makes this argument that it would be weirder if we didn't have functional neurological disorders. Like, it'd be weird if brains perfectly worked all the time. And so it makes sense that brains sometimes just don't. It's not satisfying.
Right.
We haven't figured out totally how to address these things, but it does happen.
Right. And it's it's funny you say that, because I often kind of share with patients about going to watch certain movies. Now, anybody who knows me very well knows that I'm more of a rom-com kind of girl. I don't necessarily like psychological thrillers, but my family did get me to go watch one, and it was Us. And in that movie, the family has a doppelganger. There's doppelgangers. So they have like duplicates of themselves, right? And the duplicates live in the underworld. And they basically are out to kill the family that gets to live on Earth. And during that movie, although I knew those people were in the TV, so to speak, they weren't out here with me. They were not going to tap me on my shoulder. There was no doppelganger right over there coming to get me. You still have this physiological reaction that you cannot control. Although I knew it was a movie, the hairs on my neck still stood up. And, that's kind of the best way that I feel as a neurologist. It's you can explain some of these things to patients by using those types of terms. But, I think sometimes it's not for lack of trying to get patients to see that they're not alone, that they're not, that, we hear them. We know that this disorder also has treatment. It's just that this is not treated with typical standard epilepsy therapeutic or medications. Sometimes they still feel very frustrated. Um,
Well, and that picture gets even more complicated when you add in that some patients do experience both epileptic seizures and
That's
functional
true.
seizures.
Yes, we
That's
have
And
seen
true.
that.
so it's like, hold on a second. When do I actually take my meds? All the time. Which ones
Right.
is it treating? These ones. How do I know which type of one I'm having? Well, we have to look at your semiology and figure out, like, this is what this looks like. This is what this looks like, which is not just patient education. It's often family, friend, partner
Exactly.
education as well.
Mhm.
I've heard it said before, to your point on, like watching a scary movie, brains don't always know the difference between imagination and reality, and memory, and most people are able to stay really grounded, but sometimes we can utilize that tool for better or worse. We can use it through things like hypnosis, visualization, relaxation, to help kind of train the brain and body to be like, chill out, calm down, it's fine. But like you said, we all watch a scary movie, and part of us knows it's not real. It's just on the screen. But part of us doesn't and still has that
We
startle
still jump.
reaction.
Yeah.
Right.
Yeah, same thing sometimes with other threats that come up that set off this process.
Right. And I think, Veronica, with you working in our epilepsy monitoring unit, you certainly come in contact with patients who are there to walk through the semiology of this is how my epileptic seizures look, and this is how my non-epileptic events look, and to separate those two, because we definitely need to, it's best for the patient, it's best for us once the patient realizes which box to check when they have a certain
Right.
event, so to speak, right? Was this a non-epileptic event, or was this actually a seizure? Because you definitely want to um, not get in the position where you feel like you have to make a therapeutic decision as a neurologist that involves seizure medicine for events that are non-epileptic, right? So how does that process work on your end when you see patients in the epilepsy monitoring unit?
Well, what we do is a history before they come in. We do a chart review, and so we kind of know what we're going to be looking for. And when they come in and to our unit and they have one of their events, if it doesn't look like what they have described in the past, things have changed, then we kind of know that this is probably not going to be one of their normal seizure events, that it may be going into this other category where
Right.
there's not electrical changes in the brain. And a lot of these people we have found have had some trauma in their past, and whatever that looks like, whether it's some kind of sexual trauma that they had even as a child, or maybe just like what Dr. Cardell was talking about, how they've had 7 years of trying to explain what's going on with them, and if they've had both, that's really confusing
Right.
because they've had real seizures that have looked one way and probably pretty scary to their family, but then when they have the psychogenic non-epileptic seizures, it looks a little different, and so that can be really confusing to everybody.
Yep.
So it's just trying to help them understand when it looks this way or it lasts this long, or it affects, they turn blue, things like that. Those are the kind of the symptoms that you can tell that are real and what aren't the real seizures that you need to take medicine for.
Right. And I guess one of the things you mentioned was stressors and triggers, psychological triggers and trauma. Dr. Cridell, with psychological trauma, or which could include a lot of different things, and some of these patients might experience non-epileptic events amongst other functional disorders. However, I understand that there isn't always that link, that some of the patients have not experienced this type of psychological trauma. How do you kind of help them sort out that bit? Because certainly with epileptic seizures, triggers is a big thing. You want to avoid your triggers so that you can kind of have that layer of control over whether or not events occur. So how do you help them kind of sort through that part?
No, I'm really glad we're talking about it, because I think it is one of the biggest myths that can show up around FND. as with all things, we do want to be attentive to people's psychological histories and experiences of stressors, traumas. We do know from research that there is a higher incidence of having experienced trauma in individuals with functional neurological disorders, specifically seizures. So that means that people who are experiencing these things are more likely to have had some sort of traumatic event in their past. And traditionally, we define trauma clinically as an event so serious. So there was a threat to yourself or someone you loved, or you witnessed it, and it involved really a lot of threat to like safety or life. And that can be many, many different things, right? That can be natural disaster, that can be war, that can be violence. So we know that individuals who have FND have been more likely to experience these things. But it becomes a chicken egg problem. Correlation is not causality, because when we look at the rate of PTSD, when we look at the rate of post-traumatic stress disorder, meaning that an extended period of time after this event happened, the person continues to experience symptoms of avoidance and difficulty with recall and effects to their emotions, it's less than 25%. So we have this paradox of, okay, we know that people are more likely to have experienced trauma, but a minority of them are actually experiencing post-traumatic stress. And so what that means is we have to walk this tightrope of attuning and being attentive to the presence of that, but not locking into it. And that can happen a lot of times where neurologists or family members or patients themselves will be like, okay, there must be some trauma that you've repressed or something. If there's no trauma, there's no trauma. If there is trauma, let's treat it. And I always make referrals to trauma specialists to address those things. Even if it's not related to the seizures, that's still a problem. And we
Right.
need to be able to address any post-traumatic acute stress syndromes that are showing up. But we also have to think about stress and trauma as a spectrum itself. And so even if we don't need to go all the way to the end of the trauma spectrum where we know that a patient has PTSD, we can still inhabit the space of what kind of stress have you experienced living with this disorder, and what kind of stress came up when that doctor said that thing to you or that family member did that thing, and how does that influence your behavior? Now you sort of are hesitant to go to the doctor. That's maybe not a trauma response. That's maybe a really normal reaction to a doctor saying you're crazy, which happens.
Right.
And so we can then address that as it is and say, okay, let's talk about that. Let's explore how that made you felt. Let's kind of challenge this idea that that's a universal truth about all, physicians or medical systems. Let's address, you had a seizure in public. This is a very common one. And you are now afraid of going out in public because that was really embarrassing, and maybe you hit your head and all these different things, right? But that can create this fear avoidance loop where people are afraid, so they avoid things, which makes them more afraid, which makes them avoid things. So it's tricky. My usual recommendation to medical professionals is to not ask the question and to let that be asked by a psychologist, because patients are often already so sensitive to the idea that they're making it up or it's in their head. And sometimes there's nothing we can do. I can even ask that question, and if they're really sensitive to that, they're going to get upset. But given that when we weigh the scale of things, it's less likely to be a problem at all, I usually err on the side of don't even bring it up. Stick with the facts, which is you are moving in this way, your brain looks like this. That alone is the definition of functional neurologic seizures.
Gotcha.
We don't need anything else to make that diagnosis.
That's interesting. I don't think I've heard you say before that you would actually just not even have a neurologist ask about trauma. That's very interesting, because one of the things that I notice, and one of the things that makes this patient population very sensitive about speaking about their disorder is I think as neurologists, we may unknowingly say, epileptic seizures come from this electrical activity. During your event, there is no electrical activity that was picked up, right? So this one is real and that one is not. Now, I aim every day when I wake up not to tick anybody off. That's always a goal. However, I think we unknowingly, when trying to counsel people, maybe pressing that sensitive uh, topic button unknowingly, right? So I think we may, and oftentimes when patients are sensitive about things, they kind of turn off their listening ears. They're not listening. They're not receptive anymore. Um, so not bringing up the trauma question might actually be a good thing, right? Because we don't want to add to that layer.
And I think there are ways to ask it if we are going to include it as part of our assessment. There's ways to do it sensitively. I think where I've seen things get tricky sometimes is, and this is based on old knowledge, previously in the DSM-5, the Diagnostic Manual for Psychological and Psychiatric Disorders, it was a criteria that there had to be some stressor that preceded these functional symptoms. But since DSM-4 and 5 even further, we've removed that entirely. So it's non-diagnostic. So to me, it's sort of the equivalent of like, well, sometimes patients have this, blood marker, but we don't really need it to make the diagnosis. Let's just do the test anyway. Are we actually getting something? Sometimes we are, sometimes we're not. If I had to ask the question, or if I had to coach someone in how to ask it, I would say, we do know from research that patients with FND are more likely to have experienced some form of trauma in their life, but not all patients are experiencing post-traumatic stress. Do you feel like there has been some trauma in your life? If the answer is yes, okay, we can maybe say, that sounds like something worth exploring with a psychologist or a counselor. And if they say no, we don't pursue any further. I think some people who have maybe practiced with older models of conceptualizing FND can get really fixated on like, well, you're repressing or you're suppressing, and that just doesn't happen with most trauma.
Yeah.
And so it's sort of taking patients at face value and being like, hey, if it is the case, you're not alone. This does happen, but it isn't most patients. What is it like for you? No, I can't really think of anything. Okay, thanks for letting me know that. Well, yeah, actually, this thing did happen. Hey, that might be something worth exploring. It might have nothing to do with your functional disorder, but you deserve to get that taken care of in the same way of you came to your primary care doctor because, you might have broken your toe. You also have some respiratory stuff going on. It's like, we're going to attend to both things, but we're going to focus on the thing that really needs the focus.
Interesting.
Mhm.
And I think from a neurologist standpoint, I think it's less of trying to dig for the psychological trigger for, the sake of feeling that diagnosis has to be confirmed if that's present. I think we are more, our gears turn in a clinical manner. Epilepsy is a seizure disorder, forms of epilepsy. It's a clinical diagnosis. So some patients who actually have epilepsy or seizure disorder may not have changes on the EEG. We may not see a seizure during their epilepsy monitoring unit, right? And I think we're probably not coming at the question of, do you have a psychological trigger, as like we're not looking for it as a safety net. Like, yeah, my diagnosis is right. It's more so that we're so clinically trained and that our clinical correlation is that's so important. That's bread and butter to an epileptologist, is trying to string the dots together, right? So, maybe some miscommunication there too, and that probably leads to a lot of neurologists kind of having some hesitancy with regards to approaching this conversation with patients, because we don't want to. Our goal is not to upset anybody, for sure. It's not to upset anybody. So I guess,
And all of us who operate in clinical medicine have heuristic bias. I mean, we can't, that's just human nature, right? It's like, oh, I thought the light was green, or like our brains just do funky things. And so, it's just about, as with any disease, cancer or heart disease, whatever, kind of like what's the right speed at which we, press the pedal and not go too fast,
right.
and we're all going to screw up, and we just try our best. I think too, for those of us in the healing profession, it can be really difficult to sit in that space of uncertainty, and sometimes we don't know, and we so badly sometimes want to be like, okay, we really think this is it, and And no patient wants to hear, I don't know, especially if they've been hearing, I don't know for 7 years.
Right.
That I think that sometimes makes us want to jump to a conclusion, and it's a tightrope. I talk about tightropes all the time in therapy. Life is full of tightropes.
My
We have to
goodness.
balance things.
Yeah. Which is why
I
you
think
were
it's
so
really I think it's really important to just to touch on that to when you were talking about how you approach the patient. We have the opportunity to spend a lot of times 4 nights, 5 days with these patients. And so we establish a relationship with them, and it kind of guides what approach is probably going to be best for them. And I think that comes in handy between the nurses and the physicians in our unit, because we have such close communication with each other that we're able to, kind of get a game plan before we walk in the room about how to approach, what's the best way to approach this. And yeah, and
We know that the
what's the
patient's
best
on
way with the
board.
family, what's the best way with the patients. And so I really like that we're able to communicate like that and build that rapport with the patient as well.
It's one of the great things about interdisciplinary care. We may know that patient's on board, but mom is not, or we know that
Right.
siblings got their head around it, but the patient's struggling with it. And so how can we, divide and conquer? And yeah, it's great to have, those different levels of touch and interaction with
Yes.
patients.
And that's one thing I love about our unit specifically, is that all of the nurses that are working our unit have been nurses for at least 30 years. So we have a lot of bedside experience, and I especially have a heart for just people in general. So I love to talk to people, I love to get to know them the week while they're there, and I hope that they can feel that I'm genuine in the things that I'm coming to them with and talking to them about. So I think if they trust you, that plays a big role in it too.
Yeah.
Well, that's backed up by some psychological research in terms of when we look at in psychotherapy, what is the most effective element? It's not the intervention we do, it's genuine empathy and goal collaboration. And so I think that does apply in a lot of ways to any helping professional. If you can connect with someone and be like, we're on the same plan, we want the same things, and we can have empathy for each other, that makes a huge portion of it. Just to be like, I hear you, I see you, I feel you. I also want you to get rid of these seizures. Let's figure out how we're going to do that together.
Yes.
Right. Right. And so I guess now that we're talking about treatment, that's a really good point that you make. How do you find it difficult to arrive at the goal setting for patients who may not be able to identify their triggers? How do you help them with that part?
Yeah. So one thing that I've learned in this work, and I didn't really say this at the top, I think an important preface is I was never trained how to do this. I came in as faculty here, and it was like, hey, neurology wants a psychologist 1 day a week, and that's expanded to a full-time clinical service. And I sort of learned by the seat of my pants, And so I think anyone can. When it comes to goal setting, one thing that I've learned is when I started and when I've looked at a lot of the literature and the different texts I've used, I'm happy I've got them sitting right here at my desk so I can show them off. We often want to limit healing for these disorders, for FND with seizures specifically, to a remission of symptoms. And of course, right, what patient doesn't want to not experience their symptoms anymore? But there was a really interesting study done called the CODE study, CODES. And what the CODE study found was psychologists were generally no better than treatment as usual, which is a research term meaning you just did what you usually did, which is see your neurologist. Psychologists were really no better in actually reducing the frequency of events. So what that means is, in this particular study, not all the time, patients were as likely to not have as many seizures just by going to see the neurologist as they were to see the psychologist. But what did improve when patients saw a psychologist was quality of life and satisfaction with care, as reported by the patient, their family, and their medical providers. And so what that really said to me was, when I'm doing goal setting with patients, of course one of our goals is going to be probably reducing these seizures, reducing their intensity, reducing their frequency, reducing the amount of time, but also reducing how long does it take you to recover from them, and reducing the impact on life. I have treated patients who have very successfully gone through treatment, and their seizures are not gone. But they went back to the job they love. They went back to school. They learned how to communicate about these events to others. They managed to take them from an event that would wipe them out for an afternoon to something that takes 30 seconds, and then they get back up and they go about their day.
That's right.
And I think, again, I so much want to compare these disorders to other things because sometimes we make it this exception, and it's like people live with disability. People live with chronic illness, and this is a chronic illness. We're getting to an age in medicine, thank God, where people will have chronic cancer. And so that is a weird thing to wrestle with, right? It's like, what do you mean I'm not going to get rid of my cancer? You're not, but you can live with it. And the same thing exists for many patients with FND. So when I approach goal setting with patients, it's always a conversation of not just what would getting rid of these look like for you, but what does your life look like if you got rid of them? And sometimes we work backwards from there. Well, if I got rid of them, I'd be able to play soccer again. If I got rid of them, I would be, spending time with my children. If I got rid of them, I'd be cooking. Okay, I love that. Why aren't you doing that now?
Mm-hmm.
And the reasons can be very valid, right? Well, if I have a hot pan in my hand and I'm having a seizure, that would be a problem. Absolutely. Can we work around that? How can we challenge that fear? So that's really goal setting for me is we don't just focus on one thing, because as frustrating or upsetting as it might be for some people to hear, some patients may never get rid of these.
Right.
But we also know there's a lot of chronic illness and disability that people live with and never get rid of. And so then we take an approach similar to that for, other disorders I work with in this department, Parkinson's, ALS, MS, right? There is a grief process. There is an adjustment and coping process to that. But that process involves expanding a person's sense of worth and well-being beyond their physical body and making sure they're connected with their values. So I don't always like to single out FND as like, okay, we got to do these specific things, and this is the treatment protocol. We do those things, and they're empirically validated, but we also treat it like any other disorder, which is, what does living with this look like for you?
Mm-hmm.
What are your goals for care?
Right. One of the things I like to do when I'm educating medical students is I always want to make sure that I'm kind of layering the conversation. And so what's interesting about this conversation is I feel like there's so many layers here. There's layers for healthcare workers, there's layers for physicians, there's layers for nurses, there's layers for patients. But I just want to pause just 1 second for the patient family, right? So if your loved one has just left our epilepsy monitoring unit and gotten a diagnosis of functional neurological disorder with seizures or psychogenic non-epileptic events, and that you're referred over to Dr. Kreidel, who we've said, oh, everyone loves him. You're going to, which is what we say.
It is.
He's so great. Everyone loves him. He is the specialist for what you have. What can that patient's family and that patient expect from the treatment for? Because there's certainly lots of different frameworks that you have to choose from. And we always just, I think, default to cognitive behavioral therapy. And I know that you politely say there's other things that I can do for this patient. So what can they expect in terms of treatment and then duration of treatment? How long does that typically take for like a standard referral?
It's pretty variable. I did, as you were talking, pull some of the books that I have here that we do sometimes use for treatment. A basic thing can be helping patients obtain these resources, right? Putting in an order on Amazon or wherever. Typically, there's a couple different therapies, but one major intervention we use is this book called Taking Control of Your Seizures from Kurt LaFrance, who is a big name in the field of FND, specifically FND with seizures. One thing I love about this book is it actually does really emphasize familial involvement. And the second chapter second session, third chapter, is called Getting Support. And so it's all about helping patients have a conversation with their family members about what's going on and how they can most be supportive. And so it's, we empower patients to have those conversations. I think my advice sometimes to families is, at the base, just continuing to love the person for who they are. Like, this is not, can be life-changing, but a lot of patients can really experience this shift where they are made to take on what we call in sociology the sick role. And they're made to be this, infirm, not capable, individual. And that's not always helpful. One, because it can reinforce this idea of a person not being capable if they own it. But for some patients, they're like, I love my family and I love them supporting me, but my God, like, let me go get the mail. Let me make myself a coffee. Like, I can do things. And so each family's working with patients to really kind of come onto the same page about, like, what are we comfortable with? What are we not? What can we do? What can't we do right now? And again, FND is not that unique. A lot of the same caregiver stressor dynamics show up as in other illnesses, where it can be hard to be a caregiver of someone with a chronic illness, no matter what that is. And so for families, sometimes too, I make the recommendation that they seek their own psychological care, just to process what it is like to be in this caregiver role or to see a loved one suffering. Sometimes there are family dynamics that come into play that we do suspect propagate the illness, where this may be caregiver role, caregiven role, has played out for a very, very, very long time, and it's just enacting itself here. And that's not always the case, right? When it is, that's something maybe to pinpoint and have a really tricky conversation about, because you don't ever want to tell someone, like, hey, so I'm not saying you're causing this for your loved one. You're maybe not as helpful as you think.
Right.
Or some of the behaviors you're enacting are not helping in the way you think they are. And I think that's sometimes the approach we have to take, is like, we are all just trying our best, and how can we maybe most effectively help this person we all care about, and not let our ego get in the way of it. So
Yeah.
I feel like I got off track from the question, but it's, you do have to, in all chronic illness settings, attend to the context the patient is in, which does include family.
Right. That's
Well, I think a
interesting.
lot of times too, once they find out, when we do have that conversation at the end of our stay in the epilepsy monitoring unit, and the family hears this, I kind of feel like a lot of times, most of the time, there's an enlightening that happens between the patient and the family. And I've had families ask me, so what do I do now when they have this? And I just encourage them to support them during the event, just to tell them, reassure them they're okay, and just make sure they feel safe and loved, and that they're going to get through this. And to make short-term and long-term goals, I've kind of started doing that with a lot of my patients too, where I'm like, what is a long-term goal? What can we talk about? And through that week of getting to know them, I know that maybe getting back to, like you were saying, Dr. Crydell, going back to school was a long-term goal, or traveling was a long-term goal, because I talk a lot about my travels, and that gets them excited about wanting to see different things in the world. And then what does a short-term goal look like? Today, I am not going to have an event, or I'm not going, I want to not scare my children, because I've had patients before that had small children that lived in the home, maybe, school age or teenagers. And whenever they would have an event, it would scare the kids. And just realizing that, that was kind of a goal for them to do that day, was to have their children feel safe as well. So just short and long-term goals too. But the families, I think, once you just explain to them, when they do ask that a lot, how do we handle this, is mainly just to support them during it. You don't have to run them to the ER every time, because that really hypes up a lot of emotions too when you run to the ER, and that just takes the situation to the next level. And because a lot of the ERs that they take them to may not have ever seen this before either, and so then they are assuming the patient is having an epileptic event. And so then they treat it as such, and they give them medications that maybe will sedate them. And anyway, things go on from there. But yeah, once the families and the patient kind of can wrap their mind around this diagnosis and they realize they don't have to overreact every time, kind of calm things down, I think that helps a lot.
We just completed the data collection of a research study we did on the effectiveness of a group therapy for patients with functional neurologic disorders. And one of the chapters we put into this booklet we created was on this interpersonal skills and communication with others. And we actually had a checklist that we asked our participants to give to someone in their support circle. And so it reflected sort of, here are maybe some behaviors that are maybe not so helpful, even when we think they are. So that list included becoming overly protective of the person and wrapping them in bubble wrap, taking all responsibility and making all the key decisions, talking consistently about how hard and difficult things are, criticizing or undermining healthcare practitioners because there isn't an exact cure, constant reassurance for the person, not letting them learn to tolerate some fears, frequently asking about symptoms, which draws attention to it, and introducing the person as, hi, this is my friend Bob, he has FND, as opposed to just, this is my friend Bob. So, again, I have a lot of compassion. Sometimes I don't always know how to help best, let alone, and I'm an expert in this, let alone family members, right? But, being willing and open to engage in that process goes a long way.
Yeah. I have had a patient in the past that asked me kind of that question, like you just said at the end, your friend Bob with FND. No, that's just my friend Bob. I had a patient that just wanted to know, how do I tell people I have this? And I said, well, I'm hoping you're going to get to a point where that's not your identity, that you are just who you are. And, you don't, that's not part of who you are, that you're going to get past this. That's our goal, and yes, it's okay to tell people that you're going to be around, I guess maybe your roommates and stuff, but it doesn't have to be something you just tell a person that you just meet. You don't have to identify as that.
I think labels are not good in any health condition. People just want to be known as, by their personality, who they are as a whole person, not just one thing defining them. So,
That's
yeah.
right.
And one of the things you mentioned that I thought was very interesting is, I feel like as neurologists, we're always hoping that things go down to zero, whether it's seizures, whether it's non-epileptic events, and, with drug resistant epilepsy on my side of things, when it becomes drug resistant epilepsy, they're on two medicines, whether together, take two medicines together, or they've tried two medicines sequentially and they're still having events. Coming to terms with things not potentially going down to zero is part of it, right? And so, it's interesting that you mentioned that this could also be a chronic condition. And I guess that kind of, you arrive at that conclusion when you're going through counseling, your therapy with patients. You're helping them to set goals, and they're kind of still having events. In terms of, you mentioned the duration of therapy is variable. At what point do you relegate this to it being a chronic condition and that the person is no longer necessarily benefiting from the therapy? Is it at the point where they get to be as functional as they thought they wanted to be? Like, how do you make that determination?
It's always a dialogue. It's always in conversation with patients. Treatment for FND can be very time limited and scripted. Some of the things I showed you are on a set session schedule, and you hit 12 and you're done. But for me, treatment is usually never that. A story I like to tell is a patient I was working with. I started to realize that maybe we weren't making as much progress as I had hoped we would be, and symptoms were really present. And I said, hey, I want to have a conversation about treatment progress. And I expressed these concerns. And the patient said to me, have you ever seen the movie Ghost? I was like, yeah. And she's like, when the psychic character says, you in danger, girl? She's like, I feel like you just said that to me. And so from now on, when I present on FND, I tell the story and I put a GIF of that in the corner of a slide. She's like, I think I've gotten so much better. And I said, tell me more, please. And she described all these ways in which she had made improvements. And no, the symptoms are very present, but she's learned to work around them, and her family's learned to understand them. And that just was such a lesson for me, because I was like, oh, do not limit a patient's definition of wellness to what I think it is.
Right.
For better or worse, we come up against systems, right? Insurance runs out. It's just not feasible to attend anymore. I've had patients who lost their insurance, and that is just the worst feeling in the world, that I just can't see you anymore. I think it's always about having the conversation. And I would say, you know, when we talk about overall psychotherapies for all issues, right, the general average, so to speak, is 12 to 18. I've had patients who I've seen for 2. And like just a good explanation of FND was enough to really make the symptoms go away.
Right.
I've had patients who I've seen for 2-3 years. You just have the conversation constantly. And every couple of sessions, you might come back and you say, let's revisit. How are things going? Are we working on the right things? Do we need to shift? Do we need a break? Do we need to make a referral? One of the things that's hard is, you know, this isn't really a toot my own horn. This is like, oh, I wish it wasn't this way. I'm one of the few people who I think really treats this in our region. And so sometimes, you know, we come up against a wall and I'm like, I'm really not sure how else to help you. But what I do tell patients is there are massive systems working on this. The La Silva group out in California has an inpatient treatment program for patients with FND. Active PT in California does a lot of really excellent PT, OT, and psychological rehab for FND. Mass Gen, Dr. David Perez, who is a neurologist, is like one of the big names in this work. And so what I tell people is, you know, I'm pretty good. I know stuff, but I'm not the end all be all. And so maybe we do need to look into you consulting people who really have a different understanding of this, or just you can have a clean slate, seek a second opinion. I'm never going to be offended by that. I'm not the right match for everyone. No therapist is, you know. It's not everyone we meet we become friends with, unless you're my mom. She can make friends with anyone. But, you know, and so being willing to have that humility and go, if it's not working, it's not you, it's not me necessarily. It's a confluence of factors. And I think setting out at the start, right, when we set out that we are not setting our bar as no symptoms, because that's a hard bar to clear. Yeah. And anything under it is failure. When we have a more diffuse sense of what success is, we are far more likely to achieve it. But it is hard to get to a point with patients where I'm like, I don't know. But I'll tell you, just the other day, I had a woman call me who I had not talked to in a little bit. And she was someone who I was like, I'm really not sure if we're getting anywhere. I hadn't spoken to her in a couple of weeks. And she was like, I got out of this situation I was in that was really like not great for me. And I basically have not had anything since. Patients surprise me all the time. Yeah. So it's often a lesson in humility.
Gotcha. Now, in terms of the, you know, the interventions you were mentioning, 12 to 18 sessions were kind of standard. And then the patient could maybe, if there's some other underlying things, expect to continue to work with a psychiatrist and or their neurologist and or a host of other healthcare providers based on other factors that might be at hand.
Yeah, I you know, I'll sometimes say to a patient like, hey, you and I are going to start for a little bit and we're going to get your head wrapped around some of these functional neurologic ideas, but you already have a really great relationship with an existing psychotherapist. And so let's just get you like reconnected with them and like give you some books and tools. I'm happy to be a consult for that person. And you have a great relationship, so let's not reinvent the wheel. Or you just need a little bit, I think, of education here, but I need to refer you to do this really deep trauma work. Or, you know, yeah, you're kind of in a maintenance phase, come back and see me in 3 months and let's just check in. You know, I have patients who like, I say, call me if something comes up. They'll call me, they'll say, I've had a few seizures kind of come up. Can we just do a check-in? I'm like, yeah, let's do it. And then I don't see them again for 6 months because that was enough to really, you know, it's really looking at what is it that the person needs. Psychiatric, you mentioned, I think that's worth talking about briefly. there are often comorbidities with other psychological illnesses. And so that is a conversation I do have with patients. And I say, I myself am someone who takes psychiatric medication and it helps me. I think of it as the life preserver that gets your head above the water. So therapy can teach you better how to swim. If you're drowning, it's awfully hard to do a swimming lesson. But some patients are very averse to that, and it's not something we're ever going to force. It's like, all right, I hear you. If you are open to having the conversation later, let me know. As a psychologist, that often does involve me being like, let me be clear, I don't prescribe medication. I'm a PhD, not an MD. But I can have a dialogue with your neurologist, and maybe we can have them prescribe that medication. So it's really figuring out what the patient needs and then kind of referring from there.
Very cool. So, in terms of maintenance therapy, how often do you give patients tools like mindfulness therapy or progressive muscle relaxation techniques? How often do you utilize those types of things for maintenance?
Yeah, it depends on the patient. I can say it depends to every question you give me, right? I'm a big believer in this idea that FND has different etiologies, and it doesn't always come from the same place. It's not just a trauma thing. It's not just a learned behavior thing. It's not just a like it's complicated. So when we know that etiology, or when we can kind of suss out what it might be, it helps us target the intervention. So for a patient who has a certain level of fear avoidance patterns and maybe gets really a lot of sympathetic nervous response, that fight or flight kicks in, tools like progressive muscle relaxation, deep diaphragmatic breathing, visualization, mindfulness practices can be really helpful to change their relationship to those things that set off alarm bells and go, yeah, I'm having my prodromal aura. I'm having that signal, that weird sensation I get, wherever it may be, that I might have a seizure. And I'm just going to take a moment and I'm going to practice those. And in the long term, for some patients, those are really a big part of their maintenance. For other patients, it's different skills. It's challenging cognitions. It's remaining behaviorally active with things that are important to them and that they value. It's, I like to talk about the analogy of a toolbox. I say, you got a lot of tools in this toolbox. Every toolbox does. You don't just carry a toolbox around for a hammer. You have a hammer and a screwdriver and a nail gun and. So let's give you a lot of tools, and then you choose the one you need in that moment. Do you need breathing? Let's do breathing. Do you need grounding? Let's do grounding. Do you need to put on some music and dance around? Let's do that, and not just limit you to one tool.
Awesome. Awesome. So there is a lot of cultural stigma about seeking services in any type of, situation such as this and others. Um, how do you combat that with maybe a person who's not really open to what you have to offer? Because I'm sure that also happens.
I describe it sometimes as planting seeds and opening doors, and I teach master students in our clinical psych program here, and for them, they had this experience. We have these master students do these 5-session, 6-session kind of mock therapy experiences, and they all had the experience of like, I felt like we were just getting into it, and now we have to wrap up. Like we only get to do 6 sessions. And I was like, that's okay. That's the point. Sometimes it's just about planting the seed, and someone else will water it and fertilize it. It might not be you. And so for patients who are resistant to intervention, I just have a very honest conversation, and I say the door is open. If you decide this is not right for you at this time, if you change your mind, shoot me an email, call the clinic. We'll see if we can, fit you in. I'm never going to force anyone because it doesn't work. And I think too, being attuned to intersectionality and how different communities, not just with the FND, but interact with mental health services at all. Living here in the South, there are some unique intersections for, I think, Black communities, religious communities, intersections thereof, where I've had patients who are part of those communities who have had, this message communicated to them that this is some form of maybe demonic possession or, the presence of, you need to pray more, right? And my approach to that is kind of getting their perspective. I say, well, what do you think? If part of your belief system is that maybe some of what's going on to you is other, supernatural forces, let's work with that, right? Let's, make sure you're connected with your faith community and getting, prayer and things like that. Maybe you're like, no, I think that's, that isn't it, and that bothers me. Okay, let's have a conversation about how frustrating it is to have that idea put upon you, right? Um, you know, the old adage, right? How many psychologists does it take to change a light bulb, right? And the answer is like, well, one, but the light bulb has to want to change, right? I think sometimes that joke, as funny as it is, makes it this idea that like a person has to want it, and if you don't want it enough, sometimes we don't have light bulbs. Sometimes we can't afford light bulbs. Sometimes the fuse is burnt out. We can put in a ton of light bulbs. None of them are going to work, right? So being open to the conditions that maybe limit a person being able to make that change and being okay with that.
Yeah.
Yeah, I think too that I feel like the stigma of mental health help has really come a long way in the last probably 10 years. Before it was like, I'm not going to see a therapist. I'm not crazy. And I think people now are realizing that that is not what that means. That it can really do people a lot of good to sit down and talk to somebody who's actually listening to them and being able to pour your heart out and say things that you couldn't say to anybody else in this world. But this person will listen to you and try to help you manage that and get through it. So I am
And
thankful for
even
that. That mental health has gotten a lot
even
better.
within yeah, no, I absolutely agree with you. And even in the therapy space, I'm never definitive. Like, hey, you mentioned this thing at our intake, and I'm wondering if no, I'm not ready to talk about that. Okay,
hmm
okay, that's fine. You're here to talk. I
Yeah.
have whole sessions where sometimes, like, most of it is just us shooting the bird, and like we talk about sports, but
Yeah.
that's therapeutic because it might be like one of the only times in their day where they've had someone not overbearing and being like, "You're sick," and da da da. It's like, let's just hang out. At the end, I will invariably point out, "Hey, do you notice you kind of really got through today, and you like didn't have any symptoms come up? Like what was that
Exactly.
like for you? Can we replicate this in other, I'm not billing for just, casual conversation, but that I think we often forget that human connection is therapeutic. And
Yes.
sometimes that's the most therapeutic thing we can do for someone is just be present.
Yes.
And I think we all do that. You don't have to be a psychologist. You can be a
Right.
nurse. You can be a neurologist. You can be the person who brings the food. Like,
Mhm.
those moments of human connection can be very powerful and very therapeutic, even if we're not doing an intervention.
Right. I think that's one of the things that I absolutely love about my job is getting those opportunities to just go and sit down on the couch for, a good 30 minutes and just really just have a conversation about whatever and to try to find out what lights this person up, what do they get excited about, and share some of my experiences because I've been through a lot with family members in my life with mental health and addiction and recovery and everything. And when I kind of share some of my stories, that helps them to know that I'm a real person too and that I can relate to some of the things they're talking about. Yeah. I think if we're open and honest with our patients, it can go a long way.
Yep. That's always the first step. And then I think with anything, readiness to change is something that we face with a lot of health conditions, not just this one. So somebody has to be ready to take the help. You can give even someone who has a seizure disorder, you can give them medications, but they have to be willing to take the medications. Like
That's right.
it's a give
Yes.
and take with all of this. Now, I guess, what resources would you recommend for patients who have just been diagnosed with functional neurological disorder with seizures or psychogenic non-epileptic events?
Awesome. No, that's a great question. It's something that we try and like have, I know in our clinic at least, like patients get this printout that I've designed and it's at the EMU and it's in the clinic with all these different resources. So I've mentioned a couple already. FND Hope is an international organization by and for people living with FND. And I think one of the best things they have is online support groups. So you can just get on Zoom, they have a whole calendar and connect with people living with FND, Facebook groups, things like that. Neurosymptoms.org is a website that we often recommend from Dr. John Stone, who's a neurologist in the United Kingdom. And it has some great explanations of sort of FND and the different types that exist, things we don't always consider FND, like persistent perceptual postural dizziness, or 3PD. So that's a great website. If you are a provider interested in connecting around these issues, FND Society is a great organization. It is the professional organization for providers working with FND broadly, not just seizures. And then lastly, I'll tell you, there is this article I read a couple of years back called A Cadenza for Fractured Consciousness, fndportal.org. It's an anonymous individual, I believe in England, who wrote this essay. It's a long read. It takes about an hour, but he talks about his own experience with FND. He has interviewed doctors. He's interviewed researchers. He gets into the history of FND from hysteria to modern day. I mean, it was one of those articles I read, and I was like, I have to share this with everyone. It's just so good. So FND Hope, FND Society, neurosymptoms.org, and fndportal.org are some really phenomenal groups and resources.
Awesome.
I'm taking notes.
I did too. And I guess in closure, this has been so awesome. I'm excited that we got a chance to do this today. I think it'll be very informative for patients and families and healthcare workers. But the last question I have for you is, if there was something that you felt like your patients with functional neurological disorders with seizures wanted the world to know about them, what would that be? If you could speak on behalf of all of the patients who have come to you for psychotherapy in all these many years, what would you think they would want the world to know?
I'll let Dr. Cardell go first.
And you're like, I'm not going to give you the questions in advance.
Nope.
There's a podcast that I live with OCD, and there's a podcast I listen to, and the host always does a question like this. He's like, what would you want to put on a billboard? I feel like the thing, I'm not making this up. I'm not making this up. And it's just, there are so many things that people who live with FND want to say, but unfortunately that stigma just hangs on, that it's being done for attention, that it's being done for some sort of secondary gain. And I once had someone say to me, and I just thought it was the most powerful thing, that, we say, oh gosh, they're just so attention seeking. Okay, because attention's a need. Someone's seeking attention, it's because they need attention. Calling your doctor is attention seeking, calling an ambulance is attention seeking, right? It's asking your teacher for a pencil is attention seeking, right? And so it's not attention seeking. It's not. People are not making this up. It's very real. It's a medical diagnosis, not just a psychological one. What's the difference between those anyway? That's, I feel like, something I would want to slap on a billboard.
Awesome.
Yeah, I think I would have to agree with that. I don't know if I can come up with anything better, but that they just want to be loved. I just want to be seen for who I am, and work with me with what I've got.
Very good.